this week on the BackTable podcast.
I think another critical component of communicating with patients is to start where they are, meet them where they are. So meaning taking that time in the beginning to say, tell me about what you understand about what's going on. Because not only is it going to convey to them that you're interested and you're invested in where they are, it's going to give you so much more information about how to approach them with that information rather than just hitting all those check marks, of, oh, I got to get through A, B, C, and D with them. So I think making sure and investing that time up front and finding out where they are, what they know, and what they understand is really important.
Hello, everyone, and welcome to the BackTable ENT podcast, where we discuss all things ENT. We bring you the best and brightest in our field with the hope that you can take something from our show to your practice. My name is Gopi Shah, and I'm a pediatric ENT. We have a very special guest today. We have Dr. Melanie Sulistio. She is a cardiologist here to discuss a topic that is important to all physicians having difficult conversations. She's an associate professor of the Department of Internal Medicine and Cardiology and the associate dean of student affairs at the University of Texas Southwestern Medical Center in Dallas. She has a passion for medical education and promoting humanity in medicine. Her work includes teaching communication skills that encompass meaningful care discussions with patients, as well as difficult conversations with colleagues. And she is here to share what she's learned. Welcome to the show, Mel. Thank you for coming on.
Thank you for having me, Gopi. I can't believe we're finally doing this. Yes.
Should we tell our guests our contact point is with my brother?
Can we? This is fantastic.
So. He's gonna hate it. I'm sure if he's gonna be cringing right now. But my brother Monal and Melanie, you guys were residents together at San Antonio. Yes, I don't quite remember the years of when this was happening.
We won't talk about the years because that will date me, my friend. But can we just agree that maybe part of our goal, you and me, is to make him cringe? So this is actually wonderful, right? Like this is actually part of our goals.
Absolutely. Yeah. And that his nickname is Uncle Momo. But
yes, and I will refer to him as Momo. Yes, exactly. No, all of my children call him Momo. Absolutely. And he really is we call him the Godfather, right? Because he brought you and I together, and then also the Pillar friends as well. So it's a wonderful relationship.
Well, and he's the godfather of my children and potentially many others out there because he's such a good person. He's such a great person.
He is. Totally agreed.
Yeah. So, all right. So that was our shout out to Uncle Momo. But all right. So let's get into it. We're going to talk about how to have difficult conversations today. But before we dig into that, can you first just tell our audience a little bit about yourself and your practice?
Absolutely. Absolutely, Gopi. Thanks. So I'm an adult cardiologist, as you mentioned, and in that realm, I see patients in clinic, I attend on CCU, and then I also read echoes and do TEEs. But I also like to define myself more than a cardiologist. I'm also the wife of the better half, as you know, the better half, which is Eric Staley, a physician. And I also am the mom of 3 kids who are crazy and nuts and have a very wide range of ages. So all the way from 5 to 16. So I think that all of those things define me. And I'm someone who's in love with medicine. I just absolutely love the practice of medicine, the profession of medicine. So that's who I am.
And so in your practice, what has been the experience you've had with some of the difficult conversations? Give me some examples.
Oh, sure. Absolutely. I've run the whole gamut, my friend. And I want to tell you that even though I'm talking about this as if I'm quote unquote an expert, which I am a work in progress, I think, as I will fully admit to anyone, I've run the full gamut. So when I was a resident with your brother, Uncle Momo, I certainly was no expert whatsoever. I wanted to impart my knowledge onto my patients in any way, shape, or form. And of course, I did feel like I was an expert. I probably felt more like I was an expert as an intern than I do now to this day. I think I'm more humble, 100% more humble at the current stage of my career than I was for sure as an intern. So I've run the gamut. I've run the gamut of having terrible conversations where I was potentially overconfident and really felt like I was, imparting my knowledge onto patients. I've had, difficult conversations where, maybe the patients weren't in a place where they were ready to hear some of the information that I was wanting to impart. There's definitely been times of language barriers. There's been difficult conversations because of family dynamics. And then there's also just been difficult conversations because, where I was, who I was from a cultural state, from implicit biases, from all different things that create barriers between human beings, right? I've had conversations where it just landed just in a heap on the floor, did not go anywhere because I didn't recognize all those barriers between me and that fellow human being next to me. So I've had the full gamut. You name it, I've had it not only with patients, but also with my colleagues as well. And really, I'm coming from a place of humility because I've made all the mistakes in the past, 100%.
Yeah, I like how you're able to sort of break down what makes conversation difficult by the reasons behind it, of like, the language barrier, if the patient's ready to hear the news, implicit bias, because it's so easy as a clinician. My first thought was, am I giving a cancer diagnosis, a terminal diagnosis? Right. And so, in my mind, I still break it up as something concrete like that. And yet the factors behind it, there's so much other things at stake.
Huge.
Yeah.
Absolutely. Because the topic is just one layer, right? Like the topic in and of itself, any topic that we have in medicine is already hard because we're talking about their mortality. We're talking about their way of life, and any diagnosis is going to affect people's way of life. So the topic, just in general, baseline, where you're starting from is hard, but then you bring in different backgrounds, different cultures, different biases, different expectations. And also something that we can't forget as well is we have different goals.
Yeah.
Right. So as we're coming into it as a physician, we have a goal of, okay, I need to get them from point A to point B. But the patient themselves have their own goals as well, which is they need to understand what pain I'm feeling and what I really want to accomplish here. So we may be trying to get to, this is the diagnosis that I have, like heart failure. And they may be trying to tell me, I didn't come in for heart failure. I came in because my shoulder hurt.
Yeah.
And so I think also there's all of those factors that play into these hard conversations for sure.
So just to kind of set the stage, when you have to give difficult news, or, perhaps there's an unexpected finding or, complication, or, something that you have to give, how do you set the stage? Like, how do you set it up for yourself and the patient?
That's such a great question. Setting the stage is not just the physical place or even the timing, although those are very important. So number one, setting the stage of making sure that I have enough time to have the conversation. I like to call it pulling up the chair to the bedside, right? Making sure that I have as limited distractions as possible. And then also, making sure that this is the right time for the patient, that they're not in the midst of, they're about to go to a procedure and they're incredibly nervous about that. So they're completely distracted, right, from anything that I'm going to say.
Can the patient transport come back in 10 minutes? Can y'all wait?
Right?
Yeah, it's ridiculous.
Right? They're chariot awaits, right? They're chariot awaits and they're about to be whisked off somewhere. And then you're trying to give them, some kind of hard news.
Right.
But I think the other factors that are really incredibly important in terms of setting the stage is I've got to make sure that I'm in the right frame of mind. So we all as physicians or providers, whatever it is, role that you play in medicine, we have so much going on in our lives and our minds at the same time. So we're thinking about the other, 10 patients that we're taking care of, or maybe we're worried about our kids at home because, there's something going on with our children. So one of the things that I always want to be aware of is where I am emotionally and mentally. One of the wonderful things that my father taught me growing up, he, as I mentioned, was a physician. He always said, Melanie, when you take care of patients, they're putting their faith in you. They're putting their lives, their well-being in your hands. And that is not a minor thing. And he said, you have to make sure that you're okay walking into that room, because if you're not giving 100%, and they deserve 100%. They're sick and suffering in front of us. So I think that that's something that I always carry with me, is that I need to make sure that I'm in the right frame of mind. And if I'm not in the right frame of mind, if I'm in a place where, I'm angry, I'm frustrated, I can tell that, then I need to take a step back and figure out, how do I get into a better frame of mind? Or am I the right person to even have that conversation, right? So I think that there's that, as well as, again, timing, having enough time, making sure that the patient is in a right frame of mind as well, which you don't always have control over. And then also pulling up that chair. You don't want to be standing at the doorway where it looks like you're about to bolt, and patients are wise. They know what you're feeling and what you're experiencing, and they'll read right through you. So making sure that you can pull up that chair and dedicate that time, because as we all know, if we were in their shoes, that's what we would want.
Yeah.
And I think that's critically important, as well as making sure that we put ourselves in their shoes. What would we expect? What would we want from our provider?
Yeah. And, I like the patient's time and your time, as well as the frame of mind that you're in, is it ever okay to show your emotions or your frustrations? For example, we're all, sometimes it's a lot of hurry up and wait. And it might be something so simple, just getting that scan, right? Or just going down to whatever, or getting whatever procedure. And yet here we are 3 hours behind, and there's a lot of things you can't control, right? There's just a lot going on, a lot of gears. Is it ever okay to also show how you feel when the situation is difficult for you as well? Because a difficult situation isn't, like you said, it's not only affecting the patient, you're part of the care team.
Absolutely.
And it affects all of us, maybe differently, but.
Absolutely. Wow, that's such a great question, Gopi. Yes and no. Of course, right? I'm not going to give you a straightforward answer, but yes and no. What I mean by that is that I try to be as myself and as transparent with patients as possible, because I think that one of the critical points of being a great physician or a great provider is being as authentic as you can be. I think when you show up to a patient who's sick and suffering, and again, they're putting their trust in us, when we're, trying to cover ourselves up with a sheen and put walls around us, again, I think patients are wise. They know that we are covering something up, and many times they'll be able to sense it. It won't come up maybe in the instant, but they'll later on say, you know what, they weren't telling me the full truth. So yes and no. What I mean by that is that there are times where I'm in a rush and that I'm frustrated. I have to take a deep breath. I have to control that in so much that I can. But if there are times where I'm talking to them, I will be transparent with them and say, I wish that I could do this for you. And I am also frustrated as well that this is the situation that we're in. For example, in cardiology, we're always telling them to, like you said, hurry up and wait. Your catheterization is going to happen when it's going to happen. And there is no perfect timing. I can't tell you when it's going to happen. And I sympathize with them. I empathize with them. Their family is waiting. They want to know when to take off of work to be there. And the truth of the matter is I have no control over that. So I will tell them that I may be as equally frustrated with them that I have no control over that. However, I think the importance here in terms of showing emotion and showing frustration is that I never want to get to the point where they have to comfort me. I always want to make sure that it's not so much that I'm going to lose my head, that I'm going to lose their trust, lose their respect. And also when it comes to emotions such as giving hard news, things that are really hurting me as well because I care about them, I may show my sadness. I may show the emotions that are coming out, but I'll never do it to the point where they're going to have to take care of me in the moment. Right.
Right.
So I think that's the critical piece for me is that absolutely I want to be as authentic as I can with them, but at the same time, I never want them to have to comfort me.
It's about them. It's about the patient.
Absolutely.
Yeah, it's all
how
they're
them.
feeling.
Absolutely.
Tell me about in terms of setting the stage. So in peds, I always have to talk to a legal guardian, a parent, right? I have family around. In adult medicine, how do you know when to involve other people, family members, friends, other than the patient in terms of difficult conversations?
Okay, first I have to acknowledge the fact that all of you in pediatrics, God bless y'all, because you don't have just one patient, right? I mean,
it's the family. It's the family. It's the family.
Honestly, so Gopi, I look at you and I think you superhero right there, because you not only are taking care of these kids, but you're also navigating the communication that goes not only to the patient themselves, but also to the parents. It's unbelievable. So major kudos to anyone in pediatrics, by the way. When it comes to adult medicine, at least for me, I mean, first and foremost, the clear-cut things like, do they have competence? Are they able to actually make decisions? And if they're not, then clearly we've got to get the family involved. We've got to get next of kin involved or a medical power of attorney. But also, if you know your patients, which I always strongly recommend to every learner that I encounter that you do, this is part of being a great physician. Not that I am a great physician, but always striving to be, is knowing your patients. And if you know your patients well enough, you'll know how important it is to involve those people around them. And when it is important to them and when they need their input, then absolutely, we need to bring them into the conversation. That's not always the most convenient for physicians and providers, of course. It does take a little bit of extra time, but I would argue, again, that's what differentiates the great physicians, from the ones that are more dictated by time and by how to get as many procedures done as possible. I think that's what differentiates the great ones.
Yeah, I think the extra time up front, whether it's getting everybody involved, getting, the three-way call or in person, whatever, to get it all done right up front will save you time and get everybody on the same page on the back end of it.
And can I also just add one more thing to that I think is so critically important, is that we talk a lot at patients.
Yeah.
You know what I mean? We come in with again, that we need to move the needle from point A to point B. And so we're going to come in, we're going to consent them, but in our consent, we have to get through the checklist, right? Of all the things that we have to get through. I think another critical component of communicating with patients is to start where they are, meet them where they are. So meaning taking that time in the beginning to say, tell me about what you understand about what's going on. Because not only is it going to convey to them that you're interested and you're invested in where they are, it's going to give you so much more information about how to approach them with that information rather than just hitting all those check marks, of, I got to get through A, B, C, and D with them. So I think making sure and investing that time up front and finding out where they are, what they know, and what they understand is really important.
I think that's a great segue into, it's going to ask you, are there certain questions you always ask or phrases that you have ready to sort of kind of bridge things, or if you're starting to sense not a miscommunication, but just being not quite on the same page as the patient, do you have, what do you do if you have to shift gears or it's not going in the direction that you're hoping it to go?
Oh, absolutely. I mean, such a great question, Gopi. I mean, as I just mentioned, I usually, if not always, start conversations by, tell me what you know. Tell me where you are and tell me what you understand so that I can meet them where they are. And then it's so important to read social cues. It's so important to be in tune with your patient. And what you're talking about, or at least what I believe you're talking about is, when you notice that the patient's getting frustrated, sad, overwhelmed, any of those emotions that are starting to come out, I always try to pause and not go from that point A to point B that I'm trying to get to, but say, I sense there may be something going on. Tell me what you're thinking. I really try to hone in as to what emotion they're feeling and why. I also am very cautious, and I would really advise other providers to try not to do this as well. I'm very cautious not to say, I know what you're thinking, or I know what you may be thinking, or I know what you may be feeling. I absolutely try to avoid those words because we don't know what they're thinking or feeling, unless you've experienced it yourself, unless you've had cancer yourself, or unless you've had coronary disease yourself, you don't know what they're feeling and thinking. And to say things like that can really put a barrier between you and the patient, right? Immediately put a barrier between you and the patient, because the first thing that can come out of their mouths is, you have no idea what I'm going through. And even if you have had cancer or you have had coronary disease, I would argue that now is not the time to bring that up, right? It's not about you, it's about the patient. So I avoid things like, I know what you may be feeling, or I know what you may be thinking. And again, ask them the questions. I think coming from a place of curiosity is the key. Coming from a place of humility and curiosity. Because if you come from that place, then you can't go wrong.
Yeah.
You're putting the patient in at the forefront, and that's what we should always be doing. So come from a place of curiosity, come from a place of humility. And then the other things too that I try to use in my language is I try to avoid the word but. Okay, we could go down all kinds of funny, bunny holes with it. But okay, you know what I'm talking about. Gopi, this is not just for difficult conversations with patients, but this is really difficult conversations with any of us.
Right.
So we know each other's spouses, right? This comes with even those difficult conversations with our spouses, right? You try to be nice and kind of like take the edge off, right, of something you're going to say, and you say, you're such a wonderful human being, but, right?
That's that sandwich technique, right? Positive,
exactly.
Negative, positive. Does that not work?
Right. Well, you know what I've come to find is that but, that word but negates everything you just said. So you can say all kinds of wonderful things. You could say like Aaron, right? Like, Aaron, you're such a wonderful human being. You're so smart. You're such a great interventional radiologist, but, and then you put in your zinger, right?
Right.
So I try to stay away from the word but, and I try to use connecting words like and, because and or and yet makes it that both things can be true. It's not negating everything you just said. It's both things can be true. So Aaron, or, in my case with my wonderful husband, Eric, my better half, I can say, Eric, you are so ridiculously smart. You're a wonderful orthopedic surgeon. But the same thing goes for patients. Same thing goes for colleagues, which is to say that You are clearly very well versed in your own clinical care. And what I hope to offer you is that there's another perspective here. And this is the perspective I'd love to offer you. And see, that to me is coming from a place of curiosity and humility. And if they're not ready for it, they're not ready for it. And that's not on you. That's probably the hardest part as providers, as physicians, as those individuals that want to convey our knowledge to others. The hardest part is also having the humility to say, they may not be there yet, and that's not on us, and being able to step away as well.
So I wanted to ask you a little bit more specific, when there is a patient complication or something that is unexpected, is it okay to say, I'm sorry, or I don't know? How do you feel about those phrases? I feel like there are people like, oh, you shouldn't, if you say sorry, you're admitting to something. I mean, is
Absolutely.
that like, tell me about those phrases.
Yeah, no, such a good question. I do think that there is this general, what is the word that I'm looking for? There's a general unease, shall I say unease, with saying the words, I'm sorry, because it implies that you are owning the complication, you're owning the problem, or you're owning the disease. I mean, we all know that we did not cause these diseases, right? We all know that we didn't cause these issues. From my perspective, I can only offer you my perspective. I can't say what's right or wrong. And to be very frank, I don't think that it is that simple, that there's a right or wrong answer in this situation. To be perfectly frank, I do use the term or the words, I'm sorry, but I use them. Oh, did you hear how I just said but I use them. I use them carefully. And the reason I say that is that I use them as I truly feel them. And again, this comes from that place of authenticity. What I mean by that is that as I'm looking at my fellow human being and as they're suffering, as they're going through something hard, I feel terrible that they are going through this. And I think we all can get to that place of feeling terrible that they're going through this. And so I am sorry that they're feeling this. Is it my fault? Absolutely not. Do I know it's not my fault? Absolutely. And I still feel sorry that they're going through this. So I will say the words, I'm sorry. I do think you do have to exercise caution, though, because there are instances where some may feel or think that when you're apologizing that you're taking ownership for that. Just like in every one of these circumstances, you've got to read the room.
Yeah.
If you're in a situation where you're with a patient who's having a really hard time coming to grips with what they're going through, or having a hard time, coming to that knowledge of, yes, things are going not well and maybe going in a direction that I have no control over, they may respond with anger. They may respond with frustration, and they may be looking for someone to blame. And we can recognize those instances. And in those situations, I may be much more cautious in my wording so that they don't feel like I am taking ownership for what they're going through. But there are also situations where patients are just suffering, they're hurting, and they're right in front of you. And in those humane moments and in those moments of pain and suffering, I absolutely feel comfortable saying, I'm so sorry that you're going through this, right? Mm-hmm. But you have to read the room and you have to know who you're dealing with and what emotions they're feeling at the moment, and then make the decision whether it's the right time to say that or not.
Yeah. I love read the room, because I feel like that's a life skill in any situation, right?
Right.
Like anything.
Always working on it, my friend, right? Always working on it. Not perfect here by any stretch of the imagination.
Absolutely. So, okay. Going into nonverbal cues, so like body language. Tell me a little bit about that, the importance of eye contact or, whatnot. Tell me about that.
I think this is becoming more and more important, especially in the world that we're living in medicine. And what I mean by that is you and I both know that the EMR, the electronic medical record, has become all-consuming. So it's very easy for us to treat what I believe Abraham Verghese, Dr. Verghese, a wonderful human being and a very humane physician.
Amazing writer.
We could just have a whole podcast right on that.
Oh, gosh.
But he calls it the eye patient. I've heard that he calls this the eye patient. And I truly believe that this is the case. And I try to convey this to learners I work with as well. We're not treating that patient in the EMR, right? In the electronic medical record. And it's very easy to walk into a room in the limited time frame that we have and get right on that computer in the room and then be typing away while we're also trying to have a serious conversation. So when it comes to body language, I think that there's several things. One is that, you need to sit down and give time and space to that patient the same way you would want it to be done for you if you were in that situation. And to me, that's again, pulling up that chair, not typing on the computer, and having eye contact with them. That body language is incredibly important because even though that may be the 10th conversation that we may be having with that patient that day, that 10th conversation about the cardiac cath or, the procedure or whatnot, or the chest pain, it is that person's first time to have that conversation with you. And I think we have to always remember that. So meeting them in the eye, spending that time at the bedside, really incredibly important. When it comes to other body language, like holding their hand or touching their arm, I think, again, bring it back to reading the room. I have patients who I'm clearly very close to. I've known them for years, and I feel very comfortable putting my hand on their arm because I do think that the power of touch in medicine is incredibly powerful, right? However, there may be patients you don't know that well, and you're not really sure if you should bridge that gap and put your hand on their arm or hold their hand. And in those circumstances, I think it's incredibly important that we feel okay with asking them. I would really like to put my hand on your arm because this is a hard conversation. Is that okay? I would really like to take your hand right now. Or, is it okay that I do that?
Yeah.
Because we are living in a different world these days, right, Gopi, where touch can be conveyed and construed in so many different ways. And we have to be careful. But knowing our patients, knowing what they're comfortable with, and showing our compassion in different ways. It doesn't have to be by holding their arm or holding their hand. There are going to be patients that will be incredibly uncomfortable with that. You and I both know that we run the full gamut as well, from Uncle Momo, who we would not touch, to our best friends, right? Like Gopi, I would put my arm around you in a heartbeat, right? Like 100%.
Yeah, but
right?
Definitely don't do that to Momo.
Don't do that to Momo.
No,
we know that. I mean, we know each other that way. And I would venture to say it is our responsibility as providers and as physicians to get to know our patients, to know where their barriers and boundaries are, their healthy boundaries are, and to respect those boundaries, and also show that compassion in whatever way that they can receive it.
So this might sound like a silly question, Mel, but what do you do when a patient or family member starts crying in the middle of the conversation?
Not a silly question
How do you
at all.
handle that?
Yeah, absolutely. First of all, number one, realize in my head, it means that they heard me. Because usually if they're crying, it's because we're talking about something so hard and difficult, something that's really impactful on their lives. And if they're crying, that means, yeah, it hit home. They're hearing what I'm saying. That's number one. Number two is that I always take a pause, because if they're starting to cry, they're processing. They're processing something so horrifically hard that, again, they oftentimes think that we don't take as seriously as we should. And if they're processing, the 10 minutes more of conversation or of what I'm about to inform them about is not going to land. Not only is it not going to land, it's not going to absorb. So I've got to take a pause there. And is it a pause such that I have to say, I can only imagine? That's another phrase actually that I like, by the way, because I'm never going to say, I know what you're feeling, but I'll say, I can only imagine what you're going through. And I feel that this may be a good time to take a break to let y'all process for a little bit. Because it's just like when you've probably heard these conversations, right? The minute you say cancer, they're never going to hear the next 20 minutes after you say the word cancer. So taking a pause and taking a break is really incredibly important. And the other thing is having that tissue box ready at the helm, just to show that you care enough to recognize that they're having those tears and that it's worthy of giving them something to manage those tears. Because oftentimes what I've seen other providers do is barrel through it because it's uncomfortable.
Yeah.
Right? I think there's a discomfort that naturally occurs with all of us because these are hard emotions. And if you barrel through it, wow, you're losing a really big opportunity to earn a patient's trust, and also a big opportunity to show them compassion, Yeah.
I was going to ask, I think the Kleenex box is actually a really important detail, because the worst is when you're looking around, looking in cabinets. I mean, it's, and it's just like, what am I doing? And how what am I doing? But
right.
How do you ever tell or stop by the nurse's station, talk to the patient's nurse or like the clinic nurse, like, hey,
100%.
This is, because I feel like that feedback in terms of what the nurse or other healthcare team member has spent a lot more time than we have in terms of knowing what might make this conversation, what their concerns might be. how to set it up better? How often do you do that?
Oh, Gopi, gorgeous. I just am so glad you brought this up. I try to always do this, and I'm embarrassed to admit that probably don't do this enough. If I'm on inpatient service, when I say my nurses, they're not mine. I don't own them, but the nurses I work with, wow, they're incredible, right? And if at all possible, I want to have a conversation with the nurse before I even go into the room. They know 100% more than I do. Because they, just like you said, they've been there. They know who the players are. They know what the patient's going through, and they know where, if the patient is at a place where they're ready to receive that information or not. And wow, they are our biggest allies and team members. Let's be frank. And I think this is really important to convey to every single medical learner out there. You cannot practice medicine alone. This is not a single solitary sport. And in fact, those nurses are way more at the bedside and way more with the patient than you are. So yes, before I even go into the room, talking to the nurse is absolutely critical. Talking to the techs around there, talking to the medical assistants. And then afterwards, this is probably one of my greatest joys, is getting to go talk to the nurses and tell them, hey, listen, this is what just went down. This is what they may need, because nothing unifies a team more than showing that compassion to that patient. And wow, what a privilege that is to be on that team with those incredible nurses. I mean, they honestly do so much more in terms of, taking care of their pain at the bedside than we ever do at the EMR or at that computer that's like, even on a different floor. So they are critically important. We have to have conversations with them, and we have to recognize what a meaningful role they play in all of this.
Yeah, absolutely. Right? I feel like I kind of learned that more probably in fellowship doing peds, whether it was the neonatal ICU, the, PICU. I mean, you're not touching that patient or going into that room without letting the nurse know, because if the 28-week preemie that's now, 5 weeks starts crying and I barely breathe in there, that was kind of where I first learned, like, wait a second, I need to make sure I start talking to people. And then I think after that, just making that of a habit for those reasons made me realize their help and input is invaluable to make it that
so invaluable.
Yeah, to making that our partnership better, and also making that patient overall better and the better experience for us. And on the outpatient side, whether it's my clinic nurse who's answering the phone calls, or maybe it's my speech pathologist that did the swallow study, and we got to figure out how to tell the family either we got to thicken foods, or hey, we can't. We may have to be NPO for, we got to figure out what's our game plan here. And so I think those conversations are important.
Oh, I love that. So on the adult side, one of the things that I have seen time and time again, and it's heartbreaking. I don't mean that as a pun. I say terms like heartbreaking, even though I'm a cardiologist, and I really don't mean that in terms of being a pun, but it does come out that way. Okay. So heartbreaking is that, the nurses see a side of the patients that we don't. So for example, what I see a lot of tough patients. And what I call them is hard candy shells. And the only reason I'm able to recognize that, or maybe not the only reason, but one of the reasons I'm able to recognize that is because I have a pretty hard candy shell myself, as well as, my kids. And I have a lot of friends that are this way as well. And sometimes when we're at the bedside, just, intermittently, that's all we see is that hard candy shell of the toughness of like, I can take this. And then in the quiet moments where the nurse is usually the one that's there, or the medical assistant is there, they actually open up and say, I'm really scared. And if you're able to find out that information from those individuals, how much more effective can you be as a communicator, right? And so again, I just want to hammer that point home of everything you just said. You said it perfectly, which is these people, they're our partners, in all of this. We can't do it without them.
Tell me a little bit about language barriers, having to use translation services, whether it's an in-person translator to the OD, video chat to... Tell me how to get, because that's just another challenge that's making a difficult situation even more difficult. Do you have any advice on that?
I do have some advice, although I will tell you that I'm certainly not perfect at this. I'm still always struggling to get better. First and foremost, it's not just language barriers, right? It's also those cultural barriers as well. But language barriers certainly are there, and they are just devastating oftentimes to the way that we can give care and giving compassionate care. It can be one of the biggest barriers. One thing I would say as a piece of advice that I try to tell learners is, if you walk away from a conversation and you don't feel good about it because you don't feel like it was a good conversation, you don't feel like you were able to convey, you need to come back to that bedside. Or if it's the clinic, then you need to make a phone call later, because we are so time pressed, right? We have so much time pressure in our daily lives that oftentimes we do feel like we did not spend enough time, and maybe the patient didn't fully understand. That's one thing is if you didn't feel good about it walking away, take that time later to go back and have another conversation or call that patient up with a translator. The second thing that I also like to do is show humility from the onset, right? How scary would it be for any one of us to be in a situation where we had to get healthcare and we did not speak the language? How frightening is that? So one of the things that I very intentionally do is when I walk into, so I'm just going to use the example of Spanish, right? Because that's probably the language that comes up the most that I don't fully know or can communicate with. I will walk in there and I know enough to be dangerous, Gopi. I mean, as you can imagine, right? Like I was in San Antonio for 12 years. You would think I would know more, but I don't. But I know enough to be dangerous. So, but what I do is that I know enough to introduce myself and to apologize profusely for not speaking their language. So I am putting them in the middle. I'm putting them as the center of the attention here, not me, right? It's not about my time. They're the ones that are sick. And I say, I'm going to embarrass myself here. So, hola, ¿cómo estás? Me llamo Melanie Sulistio. And then I even try to use the accent too, right? And I say, I say I'm a cardiologist, and then I say, lo siento, like I do not know Spanish. I am so sorry. And then I try to make them laugh, right? I try to make them comfortable. So I say, poquito español. Like I say it so many times to the point where I don't think that I've ever been met without someone laughing. Yeah. And then I look to the translator or to the Star Trek. I call it the Star Trek, the translating language little thing that they bring in. I turn to that and I say, mucho español. Es muy bien, right? Like, and so I always try to make them comfortable and make them laugh. And then it's also bringing that humor to me, like making fun of myself. Yeah. Because I want to make them comfortable. And I also want them not to feel like they're burdening me, but that it is my bad. I'm sorry that I don't speak Spanish, because I wish beyond all wishes that I could speak Spanish and I could understand you better. Yeah. And then I would also say the last piece of advice is, if you are in a situation where this is a really, really hard conversation, then you need to go find one of your colleagues that does speak Spanish in a way that they can convey the very subtle meanings and the compassion that you need to convey. So maybe it's not that translator that's through the hospital or through your institution. It may be a colleague that can really convey the emotion you're trying to convey, which is that you really care about them, you're compassionate about them, and this is a hard topic. Because sometimes it does get lost in translation, right? Absolutely. That's a great point.
I speak Spanish, and for some things I would talk to my patients. I would always ask them what they preferred. And, there would be times where I preferred the interpreter because it was too complicated. Sure. And I wanted to make sure they knew exactly what was going on. So I think there are different levels of comfort, ability. And I think that you hit the nail on the head, having somebody that can convey the nuances that with or without, with the translator gets lost in translation is huge, because I've heard things, I can, and I'm like, wait a second, that's not exactly. And so, I think that that's very important. Tell me about the one thing I find that can be difficult for me is, then I start speaking to the translator. Like I have to remind myself, I need to be looking at the patient. So how can we, when we're talking with the when we're talking, I guess, I don't know what the right wording is, through the translator with our patients, like how do we still stay with our patients?
Oh, absolutely. Man, Gopi, you're so good. I need to carry you around with me at all times because you really just provoke the best. Oh, you're so good. You're so good. So I will tell you, I always try to face the patient. This is where, when you were talking about body language and cues, I mean, I'm always trying to face my patient, and I'm always trying to look at them when I'm speaking. So even though the interpreter or the translator is over here and they're talking, I try very hard not to be talking to them. I try very hard to be looking at my patient so that I can convey the emotion of it, even if it's going to be translated by the translator. Yeah. And you bring up something else that I'm sorry, I'm going to veer off here a little bit if you'll just afford me this. I apologize ahead of time. Is that there's something else that I think we as physicians need to be aware of, which is in these difficult conversations, especially when we do have an interpreter or a translator, that there is an extra person in the room now, right? And there's an extra person that we've got to, that we're, I hate to say it because we're not their boss, but we're in charge of, we're responsible for them. Why do I say that? Because I've had so many situations where I've had these difficult conversations with translators, and I walk out of the room with a translator and they're in tears. And it is my responsibility to be there for them because this is not their job. They didn't choose to be a physician, right? They didn't choose to have this difficult conversation. And I find it my responsibility, as with these difficult conversations, just as with a code, right? It's the same level as having a code and being responsible for everyone that runs that code blue, is that when I leave that room, I needed to be debrief with them and I need to make sure that they're okay. And and that takes more time. Again, a lot of these wonderful things that we get to do, I like to put it in that framework, that we get to do as a physician, they take up time, and that's hard for us in a time pressure situation, which we're always in. But I would say, again, this is what distinguishes this beautiful, beautiful profession of medicine, is that it's the humanity and the science, right? So I would offer that up as well, which is don't forget about your interpreters.
Do you ever, I used to sometimes, I don't know if prep is the right word, but I would kind of explain before going into the room what we're going to talk about, more so just to make sure in terms of whether it was difficult anatomy or the concept was not straightforward, we were on the same page. And I think that prep was more, maybe less for whether it's a difficult emotional conversation, but more of a, just to we be on the same page. Do you ever do that ahead of time with something that might be emotionally difficult? Like, hey, we're about to go in here. It's going to get pretty serious.
Oh, absolutely. Yeah. Oh, absolutely. And not just with the interpreter. I mean, to be honest, I work at a academic institution. So oftentimes our teams are quite big. And you have to be cognizant of that as well as what kind of dynamic that creates when you're walking into a room, because you don't want to be like you and your entourage, right? And be staring down at the patient. So you always want to get on their level. I always prep the team. I always prep whoever I'm with if I can, unless it's a hugely urgent situation where we have to move fast. I always prep the team because, everyone is starting from a different starting place, right? And with their different backgrounds. And so, for people to take away the best that they can or the most that they can from these situations and learn from them, especially our medical learners, prepping is actually the right way to go, I feel like, so they can also look out for the social cues I'm looking out for. And then with the interpreters, absolutely. Although I have to say that usually that time is of the essence sometimes with those interpreters, but if I can prep them, I will, for sure.
So just switching gears just a little bit, I wanted to talk a little bit about having difficult conversations, not necessarily with patients now, but let's say colleagues, peers, quote, people that are, whether it's residents, medical students that are, quote, lower in the chain, if you will, whether it's in academics, or how do you apply some of these skills in other settings with other individuals?
Yes. I mean, this goes into a lot of psychology, actually, which is fascinating. This is the fascinating and the humane part of medicine, I think. But I'm going to kind of reverse back to what I said about making sure that I'm okay. So anytime that I'm going to engage in a difficult conversation, so maybe I should even set the stage for when are you going to have a difficult conversation with a colleague. A lot of that centers around, at least in my experience, around things like implicit biases, microaggressions, macroaggressions. Difficult conversations, those are definitely going to occur when you're getting into these topics, right? I think that there's several different things that I use both with patients as well as for colleagues. One is that I need to make sure that I'm in an okay place. If I'm in a place of anger, defensiveness, wanting to withdraw, which is all of those really fight or flight feelings that we feel in those really hard times, then that is absolutely not the time for me to go into a conversation like this. Or maybe I'm not the right person. So I think making sure that my emotions are in check. It's not to say that you shouldn't have emotions. It just means that you should have your emotions in check before you go in. And if you can't, you need to think, am I the right person to have this conversation? The second thing that I like to do in preparation with patients as well as colleagues is finding this place of compassionate assumption. This is what I call compassionate assumption. It's called so many different things in different realms, but the compassionate assumption is Gopi, you know me. I am an Enneagram 1. I can be very self-righteous and I'm a perfectionist, right? And I can get on my righteous high horse in like not even 2.2 seconds. I would say 0.00002 milliseconds. I can get on my righteous self, righteous high horse. And I will tell you that a way to avoid getting on that righteous high horse and getting into that place of anger is to practice compassionate assumption. What do I mean by that? What I mean by that is I need to really come from a place of this person is doing the best that they can, or this person had really justifiable reasons for doing what they did, or being what they are, or acting in the way they did. Perfect example for a patient is, man, when I was an intern, I used to get so frustrated with patients who didn't take their medications. I mean, so frustrated. I'm embarrassed by how frustrated I would get, because I would take sometimes hours at the bedside before they were discharged just to make sure and go through all of their med list. And then when they came back and they didn't take their meds, I thought, basically they're saying that everything I did and everything I was doing was worthless, when in fact it had nothing to do with me. The compassionate assumption part is the part that says it has nothing to do with my counseling. It has to do with there's 20 million other reasons why they can't take their medications. They can't afford them, or usually that's the case, is they can't afford them, but maybe it's interfering with something else that's going on with them. Like they've got a kid at home to take care of, and that there's no way they can spend 6 hours waiting in line to get their medications, right? So that's the compassionate assumption part. On the colleagues part, I think whenever you're talking about a difficult conversation, especially with microaggressions, macroaggressions, and implicit bias, I think realizing that they perhaps are coming from a place of they're doing their best. They did not intend to cause harm. Yeah. My best example that I use time and time again is, and I love this because I think this uniformly goes across every single one of us, is when you're stuck in traffic and you get cut off by someone right in traffic. And someone's cutting you off, and I don't know about you, Gopi, but I have a few choice words when that happens. I usually have a few choice words and a few choice thoughts that go through my head. And one of the things that I've had to ask myself as I've come to this realization about compassionate assumption is that, man, even especially as a medical professional, have I ever considered that maybe they are rushing because they've just been called by someone in the hospital and they've been told that their loved one is dying and they need to get to the hospital as soon as possible to be there in their last moments? Or did they just get a phone call that said, oh, your significant other is in labor, you need to get to the hospital? That is the compassionate assumption piece that I'm always trying to practice. I'm not perfect at it. I'm always working at it. But if we can find that place of compassionate assumption, I would argue that we could have so much better conversations with our colleagues and not come into it with anger and frustration and really get into these conversations that go south really quick and really amount to no progress whatsoever because we're just being defensive.
Yeah. And there's, with colleagues, there's a little bit more room for other ways in which to communicate, verbal, email, text. I mean, all that adds a different layer, I think, of how and when to address something, how far you're willing to discuss something. It's really difficult sometimes.
It's complex, right? It's so many layers of complexity. It's the hierarchical structure, especially if you're in an academic institution. It's the topic that's super hard. And then it's the fact that every single one of us are accomplished individuals and we do not want to be seen as a failure, right? And we don't want to be seen as having made a mistake. We are in a completely perfectionistic environment.
Yeah. And you're right. Is the question of, am I the right person? I think that sometimes people receive feedback better from others as well. That is something to kind of think about too. And that might be some of the, thinking compassionately about the person that you're wanting to give the feedback to. And that's kind of hard to swallow too, because you're like, I think that I'm the person that should be telling you this because I saw this and I know what you need.
Absolutely. Oh my goodness. Absolutely. And you've really got to take yourself out of the emotion and out of the situation, right? You have to go from a 10,000 foot view and you have to say, okay, number one, who does this person listen to? Who does this person admire? And then also, what could be the defense mechanisms or the defensive reactions that could occur? How can we also align our goals? I think the two that I like to emphasize are, number one, we all have a mutual goal of best patient care. And number two, we all have a mutual goal of best education for our trainees. So if we can always align ourselves, because sometimes when we have these conversations, there's a battle line that's drawn, right? And then we're arguing across this battle line. But what we want to do is remind ourselves we're always on the same team.
Yeah.
It's always about the patient, and it's always about teaching our medical learners to take the best care of patients.
So that actually, I'm glad you brought the trainees back up, because you'd mentioned, especially in an academic center, or maybe, the practice has a large team. How do you know if it's okay to take in that many people? And how do you know what I mean? For as a patient, if there is a complication or something that's difficult for me to hear, I may not necessarily want 10 people in there, or even 5. 5 is not an uncommon number when it comes to a rounding team. So how do you,
right.
and yet in medical education, these are the skills that are they're difficult to teach per se. You can't read
right.
this in a book.
Right.
My first year foundations class didn't, you know what I mean? I didn't get all this in the 3
right.
months at that time. And also I had no experience with my patients at that point as a first year medical student. So what do you do? How do you know how many people to take in a room? That's a little bit more of a concrete, maybe not, I don't know.
Sure.
And then how do you teach this? How do you expose your trainees, whether it's medical students, residents, fellows, junior faculty, senior faculty, how do you continue to learn about this as a healthcare provider?
Absolutely. I think such great questions, Gopi. One is when it comes to how many to take in the room, there's no, again, I hate to say this, but there's no right or wrong answer. It's highly contingent on the patient, highly contingent on the situation. And in these circumstances, I think the best thing to do is ask the patient, right? I think it's always best to ask the patient, because it recognizes what they want, because they're the ones that are hurting. They're the ones that are going through this. So when in doubt, ask the patient. Secondly, if you are going to bring in, more than one person, I would say, get down to eye level. I think one of the things that I absolutely can't stand is when we're standing above the patient while they're laying there, essentially in their pajamas, right? In a hospital gown. They're so vulnerable in that circumstance. And we're talking down to them, which I always think creates a very odd dynamic that's not compassionate. So taking the time to bring in chairs, and making sure that we get to eye level is huge. And I'll tell the team, you need to step back. You need to kind of sit to the side and not be hovering and making them feel very self-conscious. Hopefully not. So that's like the kind of more concrete answer. In terms of teaching, Gopi, this is the $1 million question. And I will tell you that there's an easy answer, and then I want to bring in the complications of it. The easiest answer is that when it comes to these hard conversations, the best thing that we could do is, in my humble opinion, is to simulate. Simulation is the key. I think simulation is absolutely key, because you can really suspend reality and put learners in situations where they are having these conversations and see if they can, appropriately use social cues. Can they appropriately interact with a patient without crossing, boundaries that are unhealthy? And so I think simulation is the key, not only to show, you can actually show learners these skills in simulation, as well as you can show them videos, et cetera. And then you can have them actually do these same scenarios. You can videotape them and you can give them feedback. So the simple answer is simulation. Let me tell you the hard answer, though, which is any of these skills, as you just said, these are hard skills to teach, and it's hard to write them down in a book. It's much easier to say that the BUN and the creatinine range from here to here, and this is abnormal. So because these are hard things to teach, part of the reason why they're hard things to teach is because they're hard to measure. And this is where I feel like the crisis in medical education is. The crisis in medical education is that compassionate care, humane care is absolutely critical in this day and age. I mean, we saw what happened with COVID-19. And yet, see how I use that? And yet, we are struggling. And the reason why we're struggling is because this takes time, this takes effort. And also, these are not, let's say, metrics necessarily that bring in a lot of cash flow into the hospitals, right? Into health systems, into academic institutions. It's also not typically an area that brings a lot of national attention and recognition, which is obviously something that many strive for. And so we are really struggling, I believe, in this arena in medicine. And I would say that we're almost to a point of being at a crisis level. One is that medical educators who really strongly believe in this, we are under a time pressure at all times. Number two is that when you take the time to teach these, it's hard to measure and it's hard to write papers about this.
Yeah.
That's also an issue. If you can't write papers about this and you can't publish, then you can't fulfill the metrics that's typically recognized, in an academic setting. And then thirdly, I would say that there is in general, and forgive me, my colleagues, and don't come after me, anyone who's listening to this, but forgive me, my colleagues, but I would say that in general, there is a culture of, the soft skills and the hard skills, right? And the hard skills are, doing procedures and, interpreting data and crunching that data and being able to publish that data in really high impact factor journals. What I've often been told is that I practice the soft skills. And I always laugh about that, Gopi, because, even though we call it the soft skills, they're the hardest things to measure. And not only that, they're the hardest things to measure, they're hardest things to teach. And yet I believe that they are the most important. Personally, that is where I'm coming from. I think they're the most important because without this humanity, without this compassionate care, we're never going to be able to communicate with our patients and get them to even receive our care. We saw this in COVID-19. So I think we're at a crisis right now. And I think if we don't start focusing very intentionally on teaching compassionate care, teaching humane care, and emphasizing humanity in medicine, our science will go nowhere because no one will be ready to receive it.
That's a great point, Mel. So for our listeners, or, where did you start reading more about this? What do you like to read? How does somebody who is, hey, I had this, whether it's an incident, a recent difficult conversation to, hey, this is important for me and I'm interested in this. What kinds of, what do you recommend in terms of gaining more knowledge or education about this? And I know you've written a lot about this as well. Where can people find your writing to reflect on your experience too?
Oh, thanks for asking, Gopi. I think one thing is that I have to bring up, right, is my best friend. She just doesn't know it yet, which is Brene Brown. I always I joke about that. I joke about that all the time because I always just say, Brene Brown's my best friend. She just doesn't know it yet.
She's amazing.
Right? She's amazing. And she's amazing. And I truly believe that one of the things that we have to do going forward is that we've got to take I would say probably all of the skill sets that Brene Brown puts out there. We need to start applying it to medicine. And this evolves around understanding our shame triggers, our perfectionism, and then being able to communicate effectively, drawing healthy boundaries, and then using this compassion assumption. So number one, read any Brene Brown book out there. If you throw a dart, you'll land on a good one. So read any Brene Brown book out there.
She also has Netflix specials, a Netflix special too.
Right.
So if you'd rather listen or watch, she's a great speaker.
Right. And I would also argue that her podcast, not to take away from BackTable, because BackTable
absolutely.
is amazing.
No,
her podcast, right? Yeah, her podcast, Unlocking Us and Dare to Lead, are incredible. And I recommend these to my medical learners all the time. I've learned so much from them and I listen to them over and over again, to be honest. And then another person that I highly admire is an organizational psychologist who wrote a book, Think Again. His name is Adam Grant. Incredible human being in person. And I say this, of course, because he's another one of my best friends who I've never met yet. I just joke around, but I love his work because he makes you, kind of realize that there are other ways to approach things. And so that Think Again is it will really blow up the way that we, think about medicine, and maybe we need to think about it a different way. And again, the way that I would stress upon everyone is in the way of humanity and compassionate care. In terms of my work, and I appreciate you saying this, Gopi, I think I would love to put out there, I do have an article about crucial conversations in the era of COVID-19 and circulation. Probably the work that summarizes our conversation about difficult conversations the best is my grand rounds that I just gave at Mayo for their diversity and inclusion series, grand rounds. And I'm happy to give you the link to that, as well as stay tuned, because we are taking all that I presented at that grand rounds, and we have a paper coming out shortly as soon as we can find a good home for it. So that'll hopefully be coming out pretty soon. But I'm just grateful for the opportunity to put this out there. I think it's so important. It's not about me. It's about the messaging of humanity in medicine and compassionate care.
Well, thank you so much, Mel. I think that this is going to be well received across all our shows. There's so many pearls, and I love reconnecting. I just wanted to shout out. We'd mentioned Abraham Verghese. He's an amazing
yes.
writer. For any of our listeners, My Own Country, talk about health inequity. The Tennis Partner, his own memoir, and relationship with a medical student, as well as his fiction, Cutting First Stone, all amazing and really
huge.
Yeah, amazing. For any medical learners out there, these are all great books. Of course, quote, your spare time or not. This would actually probably...
in all your free time.
Exactly. But it might actually make your difficult times even better, reading a few pages of these books.
Oh, can I offer one more thing
Absolutely.
too that I love? I actually use it to teach. I do like a book club on CCU sometimes. It's the first chapter of Complications by Atul Gawande. So another wonderful author, right? That I love, like Being Mortal, Complications, Better, etc. The first chapter of Complications is called Education of a Knife. And man, if you want to just blow up your whole thought process of medical education, read that chapter because it'll humble you. It'll cut you off at the knees in the best way possible. And I love it. So I highly recommend that to every single medical learner out there or anybody practicing medicine. It's a wonderful read.
Awesome. Well, thank you so much, Mel.
Thank you, Gopi.
Wrap. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor's Version Hess and Ivan Orgodzinsky.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening and see you next week.